Hello, and thank you for joining us for this session, which is managing recurrence. All ovarian cancer survivors worry about recurrence. And in this session, we will discuss the diagnosis and options for the management of recurrent ovarian cancer. I'd like to thank our sponsor, Genentech, for making this session possible. Our speaker for this session is Dr. Stephanie Wethington. Dr. Wethington is a board-certified gynecologic oncologist who treats patients at Johns Hopkins Medicine, where she is director of the Gynecologic Oncology Survivorship Program and also an assistant professor of gynecology and obstetrics. You can view her bio in the downloadable conference program. Thank you so much for joining us, Dr. Wethington, and I will now turn it over to you.
Hello, everybody. It is my absolute pleasure to join you today to talk about the management of recurrent ovarian cancer and to provide everyone listening their personal masters in cancer administration. So I want to start and take just a brief moment before we get into the actual management discussion to review what I mean when I say quote unquote ovarian cancer. Because as many of you know, ovarian cancer is not a single entity. It actually reflects different types of individual cancers based on where the cancer arises within the ovary. And often, actually, the most common type of ovary cancer, the high-grade serous ovary cancer, actually doesn't even come from the ovary, we now believe. The vast majority of these arise from the fimbriated or the very tip of the fallopian tube. And then they spread throughout the ovary and the peritoneum. And then what they're labeled historically has derived from where we found the largest tumor, be that the ovary most of the time, sometimes the fallopian tube, and sometimes in the peritoneal cavity. So today, for the majority of my talk, really what I'm focused on is high-grade serous ovarian fallopian tube primary peritoneal cancer that I will from now on talk about as ovary cancer. I will mention some of the other histologies, in particular the granulosa cell tumors, briefly as we work our way through, as well as low-grade tumors or low-grade serous ovarian cancers as we work our way through, but there are certainly some subtleties and distinctions to be made about the individual types of ovarian cancer and how they're managed. So what exactly is cancer recurrence? I think one of the most common questions I get when I'm sitting and talking to somebody who's first been diagnosed with a recurrence is, how do I have a recurrent cancer when all the parts that were related to that cancer were taken out in the beginning? And certainly a recurrence is a variety of things. It can be a localized recurrence in one spot. It can be a recurrence that's associated with a lot of fluid, such as ascites. It can be a carcinomatosis or a widespread recurrence. So a cancer recurrence is not a single entity. It actually can be a variety of entities. And I would describe it both as a physical entity and an emotional, mental, and spiritual entity. And so it affects everybody differently. And I'm going to touch a little bit on some of these things as we work our way through in terms of both how we manage the body in the setting of the recurrence, how we treat the cancer, and then how we treat the rest of the person in the process of treating the recurrent cancer. And so you see here a number of images that evoke that concept that we're going to talk about throughout the talk. I also want to point out that treating and managing a recurrence is not a linear path. It is not a business model of spreadsheets where you can follow a certain algorithm at each and every point and always derive the same answer. And we're not perfect always at predicting how things are necessarily going to go with one treatment or another. And so one component of managing recurrent ovarian cancer is understanding that it's going to be a little bit of a roller coaster, that there is no perfect predictive model of what is going to happen. There is no 100%. And so working within the confines of that to understand what our options are at any given moment and make good choices based on the available information that we have. So how do we categorize cancer recurrence? Well, when we first experience a recurrence of ovarian cancer, we put some labels. The first label, the most common label, relates to the degree to which the cancer is expected to respond to platinum-based chemotherapy. And we use terminology such as platinum-sensitive, platinum-resistant, and platinum-refractory to describe the cancer and the time from which the last treatment was given. So when we refer to platinum-sensitive tumors, we talk about tumors that have recurred in more than 6 months from the last treatment. When we refer to platinum-resistant tumors or cancers, we're talking about cancers that have recurred in less than 6 months. And when we talk about platinum refractory tumors, we are referring to tumors that actually grew while someone was still receiving therapy, or they increased during the treatment that the patient was receiving. Now, how do we categorize the cancer-directed treatment options? These are other categories that we use. And we have some labels and some things we can think about. We can think about whether something is standard of care. Perhaps this refers to it being FDA approved. Perhaps it refers to it being NCCN compendia listed. The NCCN refers to a guideline establishing organization that is a cooperative group of many major academic and community institutions across the country that are known for their expertise in treating cancers. And it may also refer to expert opinion based on the latest new developments in the literature. We also label things as clinical trials. This means that they are an investigational treatment, either the individual agent, a combination, or when in the treatment sequence it's being used. So when something is a clinical trial, a clinical agent, or something under investigation, this is something that is not yet proven to be of benefit sort of as a global question, or we haven't yet found the right time and the right combination to use the agent. So there are things that are standards of care, and there are treatment approaches that are clinical trials. Clinical trials require consents, IRB approval, a much more involved and prolonged process. Standards of care are things that majority of providers across the country might use, things that insurance companies are comfortable with, things that friends might know about, things that are common parlance in the community of oncology. We also label things based on what kind of treatment they are when we talk about our cancer-directed treatment options. Is something surgery, radiation, or a systemic therapy? And there are quite a few different kinds of systemic therapy today. Not the case 5 years ago, but we've had a lot of great innovations in the last 5 years. And so when we talk about our systemic therapies, we may be talking about cytotoxic chemotherapies, we may be talking about targeted agents, maybe talking about hormonal therapies, or we may be referring to immunotherapies. And so these are different labels that we assign as we begin to discuss our treatment options in the management of recurrent ovarian cancer. And so then we come to a next question. How do we categorize the actual cancer or the tumor itself? And when I say this, I mean more sort of when we're talking about the use of targeted therapies, when we want to understand the molecular underpinnings of the tumor. What has happened in these cells that have enabled them to go off the rails and behave in a way that has turned them into a cancer? And one of the most miraculous things that has happened over the course of the last 10 to 15 years is that we've really begun to understand better what makes for especially the high-grade serous ovarian cancers, but also some of our other histologies. What are some of the molecular abnormalities? And therefore, what are some of the treatments that we may be able to direct at those molecular abnormalities, take advantage of the weaknesses within the tumors, and begin to develop some therapies for these that are targeted at those abnormalities. And here on this slide, what you see is a graphical representation of some of that work that's been done by many wonderful colleagues across the country. And what you see here is how we have come to categorize our high-grade serous ovarian cancers. In particular, on the left, this graphic shows you how frequently we have BRCA1 or BRCA2 mutations, how frequently that could be something inherited or a germline mutation, or something that arises only in the tumor, or a somatic mutation. Other abnormalities in other genes are also possibilities, and these all fall in the category of homologous recombination deficiencies. And really what this means in concept is that there is something in these tumor cells that prevents the DNA from replicating in a normal fashion. And so this allows us to target that deficiency for therapies. On the right, you see the work of the Cancer Genome Atlas, and they were really instrumental in one of the first groups to do comprehensive molecular analysis of ovarian cancers, and then provide us with data that we can then use as we start to think about therapies. So now, in many treatment settings, in fact, in most treatment settings for ovarian cancer, we're using an assessment done through a company that looks at the gene mutations within the tumors and asks the question, are there abnormalities in the genes of these tumors that we can target with our therapy? And also looks for markers of homologous recombination deficiency. And we see these as important, particularly when we're making decisions about the use of PARP inhibitors. So how do cancer recurrence and treatment categories relate? So we've sort of talked about these things. How do we put them together? And I sort of have listed here for you, we have our categories of platinum-sensitive, platinum-resistant, and platinum-refractory, and we have our treatment modalities that we have available to us in each of these settings. And I would point out that the main difference falls in the difference between platinum sensitive and platinum resistant or refractory. And in platinum sensitive tumors, we tend to reuse that platinum. They're sensitive to platinum. We think the platinum is going to work. And so platinum is a primary component of our treatment. And we also more commonly consider surgery as one of our management options. So let's go through each of these and talk about how they might play into the management of recurrent ovarian cancer. And let's start with surgery for recurrence. Initially, through retrospective series from single institutions and then multiple institutions, the role of surgery for recurrence, particularly the role in platinum-sensitive disease, came to the fore. And there's been a variety of work done to further elucidate in randomized trials, which is a gold standard of deciding what the standards of care should be, whether or not surgery plays a prominent and important role in management of recurrent ovarian cancer. And what most recently, actually all in the last about 9 months, we've come to find is a series of these randomized trials has been presented, some in late 2019 and now at ASCO this year, 2 trials. And they've elucidated for us that there is a role for surgery in the treatment of platinum-sensitive recurrent ovarian cancer. And it is most important for, like all things, to personalize the treatment and select the right patient and the right surgery. And so these graphics, we love Kaplan-Meier curves when we talk about management of cancers and what treatment is better than others. These are the recent curves from these publications, and they show you can see those divisions, and you can see that in some trials we're seeing benefits, in some trials we're seeing no benefit, and the benefits differ. So in some cases saying surgery is better, and in some cases saying no surgery is better. And certainly as we get into the nitty-gritty of these trials, what we find is that patient selection is a critical component of deciding whether or not surgery is an appropriate option. So oftentimes in the discussion of the management of recurrent ovarian cancer, we'll start with the question of, is surgery appropriate? And we'll delve into the details of an individual patient's prior treatment history, their CT scan, and how otherwise healthy they are, so how fit for surgery they might be. So this is one option to discuss and consider and take into consideration with your physician. Radiation for recurrence. We use radiation for recurrence in ovarian cancer sparingly and targetedly for small single sites that are difficult for surgery and not amenable to surgery, perhaps located in bone, for instance, is one place. So there are sites of disease more amenable to the use of radiation. It is sensitive to radiation, so it's an appropriate treatment choice. But because the disease is often thought of and treated as a systemic therapy, radiation is not one of our primary modalities. We think more in terms of surgery and then systemic therapies for the treatment. And when we talk about systemic therapies for recurrence, we have many options. And the table on the right, I mentioned the NCCN earlier. The table on the right shows the list of some of what they consider the standards of care in the management of recurrent ovarian cancer, divided into our categories of platinum sensitive and platinum resistant. And you can see there are many options. The other thing that is wonderful and very exciting for all of us who are treating women and for the patients who we're treating is that in the last couple of years, we've seen an acceleration in FDA approvals in ovarian cancer. And my table is skewed so that I've got more space to work with the recent approvals. But in the last 3 years alone, we've had the introduction of PARP inhibitors. We've had for management of maintenance therapy. We've also had the of pembrolizumab for a narrow window of patients who have MMR deficiencies or sort of another targeted therapy or targeted agent. And we've also seen a little bit longer ago than that, but still within the recent past, the combined use of Avastin with some of our chemotherapies. And so we have recently, in the last few years, seen a great acceleration, which is very excited and opened quite a few doors of opportunity for treatment. So here we see some of our FDA approvals. So as you can see, many, many options. So when we talk about cytotoxic chemotherapy kills cancer cells by damaging the DNA that is inside the nucleus of the cell and by keeping the DNA from dividing and growing in the fashion to which it has become accustomed. So that's how our cytotoxic chemotherapy agents work. PARP inhibitors, in contrast, target DNA repair pathways and specifically single-stranded DNA breaks. The mechanisms of DNA repair are elegant and beautiful, and they're designed to be perfect. And so there are safety gaps put in place. Single-stranded DNA breaks can occur, and as you remember, we all have a double helix, so we have 2 winds of our DNA. And when you have a single-stranded break, there's a break in one of the two. Single-stranded breaks, when left to their own devices, become double-stranded DNA breaks, and there are repair mechanisms for both single-stranded breaks and double-stranded DNA breaks. When you have a PARP inhibitor, the PARP inhibitor prevents the mechanisms for single-stranded break repair, and so the single-stranded breaks become double-stranded breaks. In one setting where there's intact or normal double-stranded repair, then you have repair of the DNA, all is good, and the cell can replicate. But if you have a PARP inhibitor that prevents single-stranded break repair and you have a homologous recombination deficiency that prevents the double-stranded break from repairing, the cell is not able to go into its normal replicative process and the cell dies. And that is the goal of PARP inhibitors. They are designed to take advantage of that homologous recombination deficiency in the cell and therefore lead the cell into a cell death pathway instead of a cell growth pathway. And so the best thing about the PARP inhibitors is not that they have an elegant mechanism, but that it actually works when it's translated into women who have high-grade serous ovarian cancers. And beginning in 2017 and continuing up until the present, we have had the introduction of multiple FDA approval indications in the maintenance setting that are more broadly available to many women with high-grade serous ovarian cancers. There had been an earlier indication in the multiply recurrent disease setting, but not in the early setting, and not now for many, most, and some argue maybe even all someday women who have high-grade serous ovarian cancers. So these graphics are some of those Kaplan-Meier curves that we all have come to love. And the nice thing about these graphics is that each and every one of these curves shows benefit to the women who received it. And we do see differential benefit in terms of who's receiving the drugs and what their survival benefit is from the drugs based on what type of homologous recombination deficiency we have. But there are now studies to show that in different settings, all women can benefit, and even more recently, benefit from combinations of PARP inhibitor with, for instance, a VEGF inhibitor. And so the goal of PARP inhibitors, when to use them, how to use them, these are all questions that are developing and are very reasonable to ask when you're in the position of making decisions about how to manage your recurrent ovarian cancer. VEGF inhibitors, I just mentioned them in combination with PARP inhibitors, and that is certainly one of the new FDA approvals is a combination of a PARP and a VEGF. But the VEGF inhibitors work by focusing on blood vessel growth. So tumors need blood, and in order to ensure that they have blood flow to them, they secrete VEGF, which stimulates the development of blood vessels. And so VEGF inhibitors prohibit this process. And without the increased blood supply, the tumors effectively sort of starve. And so that is how these agents, conceptually, how they work. And they are, fortunately, quite effective. VEGF inhibitors, particularly the most commonly referenced, is bevacizumab. And this agent has been shown to be effective in the upfront setting, in the platinum-sensitive setting, and in the platinum-resistant setting. And so many women over the course of their therapy end up using these agents at some point during the treatment. And again, it becomes about asking the question of when is the appropriate moment for me? Immunotherapy. We keep trying, we're searching, we're looking for the right way and moment in time and mechanism in which to use immunotherapy. And so I'm going to talk generally about how immunotherapy works. I mentioned the indication for pembrolizumab and ovarian cancer. It's actually a broader indication, not specific to ovarian cancer, but specific to tumors that have mismatch repair deficiencies, which is another type of DNA repair mechanism abnormality. And so other than that one narrow indication, by and large, unlike the PARP inhibitors, where we have seen a big expansion in the role of PARP inhibitors for high-grade serous ovarian cancer in particular, we haven't yet seen a comparable expansion across the board in immunotherapy. We're starting to see some subsets of patients who may benefit in particular. And so there's subsets, particularly our clear cell ovarian cancers, but not the global benefit yet. So I'm going to talk generally about how immunotherapies work. And often the context in which we are using them is in the context of clinical trials. So CAR T-cell therapy, just briefly to explain, because this is something that's taking place in clinical trials and gets talked a lot about in the news. In the case of CAR T-cell therapy, blood is collected from the cancer patient, the T-cells are removed, and then they are genetically altered to have special receptors, and then many of these T cells are generated. The patient receives chemotherapy to sort of deplete the immune system a little bit and then introduce these T cells back into the system. And these T cells are primed to then go and attack the cancer. So this is a very patient-specific method. And right now, if you go to clinicaltrials.gov, for instance, you will find that there are a number of trials going on to assess this in the case of high-grade serous ovarian cancer and other cancers. Checkpoint inhibitors, pembrolizumab that I mentioned earlier, would fall into this category. Tumor cells are tricky. They want to hide from our immune system. And so they have developed ways in which to inactivate the native immune system and prevent it from recognizing the tumor cells. And so checkpoint inhibitors, such as the pembrolizumab that I mentioned earlier, as well as other PD-L1 and PD-1 inhibitors, they're able to block this and then unmask the tumor cell, which then allows the immune system to recognize the tumor cell and to attack it. These are a very popular clinical trial component right now and have been used in many other disease sites and commonly do get mentioned. So how do clinical trials work? I've mentioned them a few times, particularly as we were talking about the immunotherapies, as this is an area of active research. The difference between a standard of care therapy and a clinical trial is really that the clinical trials are designed to answer a question. And depending on the phase of the study, there are different questions that are trying to be answered, and then each trial will have its own design. Typically, when you talk about a phase 1 study, you're talking about a safety study. So they're assessing what are the toxicities of the trial, what is a safe dose to give, and is this drug a safe drug to give in humans? And in different combinations. So sometimes it's a single drug that's never been used in humans before or has been used but perhaps in a different disease site. Sometimes it is a matter of a combination that's being tested. So it's focused on safety. A phase 2 trial is more focused on efficacy, establishing what percentage of the time in a particular population response is seen. And these phase 2 are then the groundwork for moving on to phase 3 trials. And phase 3 are when you hear us talk about comparison trials, when we're comparing two things to each other to determine whether one is superior to the other, or maybe just whether one is not inferior. So is something equivalent? And it might be equivalent from an efficacy standpoint, but it might have toxicity benefits, for instance, meaning it has fewer toxicities, not that it has more. And so there are different ways to set up the comparison, and there are different elements that can be looked at in the comparison, both efficacy elements, quality of life elements, for instance. And then phase 4, we don't really talk about that too much, but there is an element of post-market surveillance that occurs. So our clinical trials are designed to answer a question. We have different levels of them, but all of them, regardless of which phase they are in or what particular question they're asking, are heavily governed by IRBs, which are in review boards, institutional review boards. And these really make sure that there is safety within the trial, that there are mechanisms to make sure that there's appropriate follow-up and testing and all sorts of things that need to be in place. And so all of them don't occur at random, but actually through a very structured process. And so in that sense, that's where the safety of the trials are maintained. And so where do you find clinical trials? This is often a big challenge. Anybody who has tried to identify a clinical trial for themselves knows that it's actually very hard. There is no simple answer. There are wonderful databases like clinicaltrials.gov that contain within them all of the ongoing trials, past and present. They have to be updated, and so it's not always necessarily the best indicator of what is active in that given moment. And by active, I mean accepting new patients. It also doesn't necessarily have enough information so that you can figure out whether or not you are actually eligible for the trial. Often it will have some indication, does have things like an inclusion criteria and an exclusion criteria. But often the subtleties or some of the specifics aren't able to be included in that. So even when you see something on clinicaltrials.gov, it then requires calling institutions, and it always has those listed, to see if they have the trial available, asking your practitioner, what trials do you know about? What trials would your oncologist recommend for you? So looking on your own, but then raising the question. And often what I tell patients and how I frame any treatment decision, I always break it down into those two categories I mentioned earlier. what are our standard of care options, what are our clinical trial options. And then there's clinical trials at your home institution, and if you have the means to travel or have family somewhere else that you could stay with, whether they're clinical trials at other locations that you might be interested in. There are some non-clinicaltrials.gov databases and resources. I have a graphic here of one of them. The Ovarian Cancer Research Alliance does have help with this, and there are other institutions. So if you go online and Google, you can find these. Where to find a clinical trial is a short question, but a very long answer that does involve quite a bit of legwork, admittedly, and can be a challenge. So don't be discouraged. If you go looking for a clinical trial and you can't quite find your way, it's not you. You're not missing anything. It can be a challenging process. So what are other treatment options? I've very much focused on cancer-directed treatment options, and there are actually other cancer treatment options that may not be directed at the tumor itself. And here I have a list of many of these to consider and to incorporate into your treatment plan. Nutrition, seeing a nutritionist. And I don't mean any unusual diets necessarily, any extreme diets. In fact, I'd be cautious about extreme diets, but just meeting with a nutritionist to talk about healthy eating. Some people, when they're receiving chemotherapy, notice a change in appetite, a change in what they tolerate, and a nutritionist can be very helpful to talk through what looks good, what is appealing, what suits you, what may be best for your digestion as you're going through your therapies. Exercise. Exercise can come in many fashions. It can be a walk with a good friend or a partner. It can be running if you're a runner, or swimming, or going on a bike, whatever your form of exercise may be. It also could be rehab with a physical therapist. So one thing that can happen as people are receiving treatment pre or post surgeries is the process of rehabilitation or strengthening of the body. And I think physical therapists are a gem and a jewel in this, and can really be very helpful when people are feeling fatigued or weak and not able to quite get themselves there on their own. They're also able to help with some of the unique things that cancer survivors face, like lymphedema. Many women who've had lymph nodes removed as part of their staging surgeries or removal of cancer surgeries at their initial diagnosis will develop lymphedema, and the physical therapists can also often help with this. Including intimacy and support with our family and friends and our partners is also part of our treatment. Maintaining our mental health through the process, our spiritual focus, and so turning to friends and family for this is very important, but also our fellow cancer survivors. Our primary care doctors can be a critical part of our treatment. They can help with the management of the diabetes and the hypertension or other medical comorbidities we might have. So holding on to them and making them part of our treatment plan can be very helpful. On the right here on the column, I have a number of our other specialists that I think are important to figure out how you interact with as you make your treatment plans. Palliative medicine, clergy members, social workers, psychiatrists, psychologists, and integrative medicine specialists all have something to offer in setting up our treatment so that our mind, body, and soul are well taken care of during our process. For many patients, things like massage, acupuncture, and I label them medications and not herbs because I want to make the point that they can have biochemical effects in our bodies, and so anything you use from any doctor, your oncologist, should be included in. But all of these things could potentially be integrated into your treatment plan in consultation with your oncologist and are worth asking about and worth pursuing as you're managing your recurrent ovarian cancer. And I want to delve down a little bit more specifically into palliative medicine and what it is and why I emphasize it in my previous slide and why I'm now going to give it a little bit of extra attention for 2 more slides. So what is palliative medicine? It is a medical specialty. Individuals who specialize in palliative medicine have completed fellowships or have been grandfathered in and are experts in palliative medicine. It is often something that oncologists have good training in and do themselves. Some institutions have dedicated palliative medicine teams. Palliative medicine is a growing number of practitioners, but sometimes not in all communities. And so often an individual oncologist will take on the role also of the palliative medicine specialist. And really what distinguishes palliative medicine is what the care goal is. It's a care guided by the needs of the patient, not the cancer prognosis. And it really integrates the physical, psychological, and spiritual elements to provide relief for the symptoms and the stress of the cancer. And so it takes a slightly different approach than asking, how do we treat the cancer to make the cancer go away? And we have great treatments for that. And as I indicated earlier, we have new burgeoning areas of research and we have new treatments that are coming up. But we still have symptoms and stresses of cancers that need to be addressed. And these can be things as simple and common as pain or nausea and vomiting, constipation, GI symptoms that are bothersome, the anxiety and nervousness that happens. The anxiety and nervousness that happens at the diagnosis, at going for CT scans, going for therapies, concerns about developing the side effects, depression that can be very common. Some women, if they have fluid or in different situations, can develop difficulty breathing, and they can be helpful with these symptoms. Changes in appetite in concert with the nutritionist. This can be a good pairing to help with that. Fatigue, being tired, so common. The most common symptom can be helpful, and also difficulty in sleeping. And this is not all that they address, but this is certainly one component. They help not only the patient themselves, but also they can help the caregivers of the patient so that there's a full team that's being taken care of in the care of the patient. And so they can be very helpful. They also can help when individuals have questions about advanced care planning and developing and articulating their wishes in their care process. And so this is an adjunct or an added on to the cancer-directed therapy. And so I think often, one of the questions I get from my patients is, why do I need palliative medicine? Why can't you just do this for me? I don't need to go to another doctor. I don't need another appointment. You take care of this. And I do emphasize and sort of back up and talk about some of the research that supports the use of palliative medicine. I point out that actually it's an ASCO guideline. So one of the ASCO guidelines is that patients with recurrent cancer receive a consultation with a palliative medicine specialist or have a palliative medicine assessment in the case where there's not sort of a fellowship trained person nearby, but have a palliative medicine assessment within the first 8 weeks after that diagnosis of recurrence. So it's really about following a guideline, but the guideline exists because there's some nice data behind it that shows that patients who receive palliative medicine as part of their cancer management plan actually demonstrate less anxiety, fewer symptoms, and actually even at the end of the day, a shift in survival. And so there are benefits around the use of this in the treatment plan. And again, I want to emphasize this can be provided by a fellowship trained specialist, and that's all they do. And in settings where there isn't access to someone who has specialized training in palliative medicine, the oncologists do. So it is something that is increasingly available to everyone and can be provided in slightly different settings in different ways. So what about caregivers? I've focused most of this talk on patients, and I mentioned in my last little slide a little bit about caring for patients and their caregivers as part of what palliative medicine does. And I just want to take a brief moment to focus on the caregivers, because part of our management of recurrent ovarian cancer is that there are people who care for the patients when they're not in the hospital, when they're not getting treatment, when they're not in the doctor's office with us. And these caregivers are a critical part of the treatment plan. Patients can't get through their treatments without them. And so finding ways in which to support the caregivers becomes important. And also, I just want to take a moment to remind the caregivers that finding ways for them to also take time for themselves and take care of themselves, because if they are not healthy and taken care of, it's hard for them to take care of the woman who's being treated for recurrent cancer. So our caregivers play a central role. They help take care of patients when they're not in the hospital or in the doctor's office. And they're critical askers of questions, and they're critical folks who can help identify resources for support. And there's a lot of online resources for support. There are also a number of burgeoning peer mentorship programs throughout the country, and there's group and individual therapy. And even the caregivers need to remember, as I put on the prior slide for the patients, seeking the help of family and friends. So caregivers play a critical role. And as we're thinking about our treatment and management strategies, we also need to make sure we have in the back of our minds that respite for the caregivers and making sure that they have what they need to get through the process also. The last thing I want to talk about is drawing inspiration. And I think one part of making our plans as we address how to manage recurrent ovarian cancer, we have our treatment-directed therapies, we have our supportive therapies and our adjunctive therapies, we have our caregiver therapies, and then we have, where do we find inspiration through all of this? Because it's a long process and a lot changes. So I mentioned some framework, getting that master's in recurrence administration, and what is the language to talk about? What are the questions to ask about? What are some of the therapeutic strategies that are on the forefront to ask as you're making your plans for therapy and finding out where they fit in for you? But it's a long process. It's not a short process because of all these great treatments that we have. It's no longer as much an acute disease when it recurs. It's often a chronic disease, and so we think of it as such. And so finding inspiration on the days when the process seems very long can be very hard, and different people draw inspiration from different places. And so I just want to end by saying that in the course of making your treatment plans, always remember to also make your inspiration plans. And maybe it's in the folks who are doing the research, and there is some incredible research going on all across the country. So maybe it's those folks who bring you inspiration. Maybe it's some of what's been written. If you go to Amazon and just Google ovarian cancer, you'll get a bunch of books that come up as good reading options, and I've highlighted a few here. Finding resilience, things, good words, and hearing other people's experiences, so you realize where yours is similar and unique, because everybody has similar and unique components of their process. And then looking to others, whether it's a famous figure who's showing us how to work through the process, or it's friends and joyous companions. And this lower figure here I use because it's a number of women who I had the pleasure of treating in the past, and they have a video online, so I'm not revealing any HIPAA information that's private. This is a public screenshot that I took of their video singing and being inspirational. And so as you work on your treatment plan, don't forget, there's a lot to treatment. There are a lot of different components. There are a lot of questions to ask. There are a lot of wonderful therapies here and on the horizon, and combinations of therapies here and on the horizon. So ask lots of questions.